The clipboard is cold when they hand it to you. That is the first thing you notice. Not the fluorescent light above the bed, not the sound of someone's monitor 3 curtains over. The clipboard. It is heavier than you expected. 6 pages, 2 signatures required. One line at the bottom of page 4 that says, "I understand the risks, including death." You are sitting in a gown that does not close in the back, holding a pen you did not bring, about to sign your name to a surgery that was recommended to you 11 days ago. And no one in this room has told you the one number that would change what you do next. That number exists. Your surgeon knows it. The hospital's own calculator generated it before you arrived. It is a percentage. Your percentage. The specific likelihood that this operation, on this body, at this age, with these conditions, will end in a way no one in your family is ready for. It is not on the consent form. Over the next hour, I am going to walk you through 5 heart surgeries that are silently killing seniors after 65. Not because the surgeries fail, because the conversation before the surgery fails. You will hear the name of each procedure in plain English. You will hear what happens to real people who sign that clipboard without knowing what I am about to show you. You will hear the specific questions that change everything, the alternatives that exist right now, and the one sentence you can say in that room that most surgeons do not expect to hear from someone your age. By the end, you will not need a medical degree. You will need 3 questions and the willingness to ask them. Here is the first thing worth knowing. You check your blood pressure in the morning, maybe twice, once before coffee, once after. You write it down in the little notebook on the counter, or you tap it into your phone if your daughter showed you how. You bring that notebook to every appointment. You sit in the waiting room with it on your knee, and you watch the clock because your appointment was at 10:15 and it is now 10:52. And when the doctor finally sees you, you open the notebook and show them the numbers. And they nod. They say the numbers look fine. They say, "Keep doing what you are doing. You have done everything they asked. You took the statin. You cut the sodium. You walked the neighborhood even when your knee said not to. You showed up for every stress test. You paid the copay every time." And the numbers have stayed in range mostly for years now. And still, there is a morning or a scan or a routine check that finds something the numbers were never measuring. A valve that has been narrowing so slowly it never set off an alarm. An artery that has been building plaque behind the wall of a reading that looked normal on Tuesday. And the same doctor who told you the numbers were fine is now sitting across from you saying the word surgery. And the number on your notebook, the one you have been so careful to record every morning, has not changed at all. The question you are asking right now is not whether to trust your doctor. It is bigger than that. It is whether the system that tracked your numbers for 10 years was tracking the right things. That question is what the next hour answers. And by the end of it, you will not be someone who fights their doctor. You will be the person in the room who reads the consent form the way it was actually written. And there are 3 kinds of people watching this right now. The first kind is the person who already has a surgery scheduled. It might be 3 weeks away. It might be next Tuesday. Someone handed you a date and a time and an instruction sheet, and you are doing what you were told. You are watching this because something does not sit right, and you cannot name it yet. The second kind is the person whose husband or mother or father just got a recommendation. You were in the room when they heard the word surgery. You watched their face. You have been searching the internet at 11 at night trying to understand what was just proposed, and nothing you have found sounds like it was written for a real person. The third kind has already been through it. Someone you love went in for a procedure and came out different, slower, quieter, less, and you are watching because you want to understand what happened. You want a name for the thing nobody warned you about. All 3 of you are about to hear the same 5 procedures. All 3 of you will leave with the same 3 questions. And all 3 of you are going to realize the same thing. The most dangerous moment in a hospital is not the surgery itself. It is the 10 minutes before you pick up the pen. Picture this. You are sitting in the small exam room again, the one with the model of a heart on the counter and the poster of a circulatory system you have looked at 40 times. Your doctor is explaining a procedure. They are using words you half recognize. You are nodding because nodding is what you do in that room. But this time you open a folder. You printed something out last night. It is 1 page. On it, you have written 3 questions. The first question has a number in it, a specific percentage, that you are going to ask your surgeon to confirm. The second question names an alternative procedure your surgeon has not mentioned. The third question is 5 words long, and it is the one that changes the whole room. Your doctor stops mid-sentence, looks at the paper, looks at you. And for the first time in 12 years of appointments, they sit back in the chair and say, "That is a really good question." Now picture this. It is Thanksgiving. Your brother-in-law is talking about his friend who just had a heart procedure. Your sister is worried because your father's cardiologist mentioned something about a valve. The table is getting quiet the way it does when someone mentions hospitals. And you say one sentence. You say, before he signs anything, ask them what his STS score is. Everyone looks at you. Your sister asks what that means. And for the next 4 minutes, you explain it in words a person can actually understand. No jargon, no lecture, just the thing you wish someone had told you before you signed your own clipboard. That is where this hour is going. Walter was 71, retired electrician out of Akron, Ohio. Hands like leather, voice like gravel, and a medicine cabinet organized better than most pharmacies. His daughter, Christine, kept a yellow legal pad on the kitchen counter. Every time a doctor visit was coming, she would sit at the table and write questions in blue ink. 14 questions on that pad the morning they drove to the Cleveland Clinic for his cardiac consult. She had researched every one of them. Not one of those 14 was the question that mattered. Walter had triple vessel coronary artery disease. 3 of the major arteries feeding his heart were partially blocked. The cardiologist recommended a CABG. In plain English, that is a coronary artery bypass graft. They open the chest, take a blood vessel from the leg or chest wall, and reroute the blood flow around the blockages. It is one of the most performed heart surgeries in the world. Walter was the textbook candidate. He walked 2 miles every morning before the sun came up. He had not smoked in 19 years. His blood pressure had been managed with medication for a decade. His cholesterol numbers were better than his daughter's. The surgeon said his case was straightforward. Here is where most people predict what went wrong. You are probably thinking Walter skipped a medication, or that he had a condition nobody caught, or that the surgery itself went sideways. None of that happened. The bypass was successful. All 3 grafts took. The blood was flowing where it was supposed to flow. The surgeon came to the waiting room and told Christine it went beautifully. Walter woke up on Wednesday. By Friday, Christine knew something was different. He could not find the word for refrigerator. He called it the cold thing. He asked her twice in 1 hour what day it was. He put his shoes on the wrong feet and did not notice until she pointed at them without saying anything because she did not want to embarrass him. What happened to Walter has a name. It is called post-operative cognitive decline, and it does not show up on any consent form as a percentage. The form says, risks include cognitive changes. It does not say that for patients over 70 undergoing CABG with full general anesthesia and cardiopulmonary bypass, the rate of measurable cognitive decline at 6 months is between 30 and 40% in some studies, 30 to 40 out of every 100 Walters. Think of the consent form like a door. You sign it, you walk through, and the door locks behind you. On the other side is the surgery, the recovery room, the weeks of healing. But what nobody showed Walter is that there were other doors in that hallway, doors that led to the same destination, the blood flowing where it needs to flow, but through a shorter hallway with the lights on and without the thing that took his words away. For Walter, one of those other doors was a procedure called PCI, percutaneous coronary intervention. Stents placed through a catheter in the wrist, no open chest, no heart-lung machine, no 6 hours under general anesthesia. For certain patients with stable coronary artery disease, the outcomes at 5 years are comparable. The question is, which patients? And that question was never asked out loud in Walter's exam room. Christine found this out 7 weeks later, sitting in a support group for cardiac caregivers in a church basement on a Tuesday night. A woman across the circle said her husband had the same blockages and was offered stents instead. Christine went home and looked at the yellow legal pad still sitting on the kitchen counter. 14 questions in blue ink, and the 15th question, the one that would have changed everything, was never on it. What happens to his mind? I want you to hold on to that image, the legal pad on the counter. Because the consent form Walter signed was not designed to answer Christine's questions. It was designed to protect the institution that performed the surgery. That clipboard is not your friend. It is the hospital's. And the door you think is the only door is almost never the only door. In the summer of 2019, a hospital system in Houston ran the numbers on their cardiac catheterization lab. They were proud of what they found. Stent placements in patients over 65 were up 34% over 3 years. Procedure volume was the highest in the region. The brochure they sent to referring physicians had a sentence in bold that said, "Restoring blood flow, restoring life." What the brochure did not include was the readmission data. Here is how cascade stenting works, in words that do not require a medical dictionary. You go in for chest pain, stable chest pain, the kind that shows up when you climb stairs or carry groceries but goes away when you rest. The cardiologist threads a catheter through your wrist or groin, looks at the arteries on a screen, and finds a narrowing. They place a stent, a tiny mesh tube that props the artery open. You feel better. For a while. 3 months later, a follow-up angiogram shows another narrowing downstream, another stent. 6 months after that, a third. Each procedure is billed as necessary. Each consent form is signed in the same pre-op room with the same gown and the same pen. And each time, you believe you are one stent away from being fixed. Here is what you are probably thinking went wrong. The stents failed. They clotted. The metal caused a reaction. Something mechanical broke. No, the stents worked perfectly. Every single one of them did exactly what it was designed to do. The artery stayed open at each site. The problem is that for stable chest pain, the kind that is not a heart attack, the kind that comes and goes, stents do not prevent heart attacks. They do not extend life. A landmark trial in 2019 involving over 5,000 patients showed that for stable coronary artery disease, stents plus medication performed no better than medication alone at preventing major cardiac events. Read that again. Medication alone performed the same as the procedure. The stents relieved symptoms. They made the chest pain go away faster, but so did the medication within a few weeks. And the medication did not come with blood thinners for life, contrast dye that taxes the kidneys, bleeding at the catheter site, or a small but real risk of stroke during the procedure. The hospital in Houston was not doing anything illegal. They were not placing unnecessary stents in the way a corrupt mechanic replaces parts you do not need. They were following a protocol that had been standard for decades. The protocol said, find a blockage, fix the blockage. It made intuitive sense. It made visual sense on the screen. It made financial sense for the hospital. It did not make clinical sense for a 72-year-old with stable symptoms and 3 other conditions already managed by medication. The consent form for each of those stent procedures listed every risk: bleeding, infection, allergic reaction to contrast dye, damage to the artery, stroke, death. What it did not list was the most important piece of information. For your specific condition, there is a good chance this procedure will not change your outcome compared to taking a pill. That is the second door no one showed them, the door marked medical management. The door that leads to the same 5-year survival rate without the catheter, without the contrast dye, without the blood thinners, and without the 4th trip to the pre-op room in 18 months. The hallway was always there. The other door was always unlocked. But when you are lying on a table looking at a screen that shows a narrowed artery and a cardiologist in scrubs is pointing at the dark spot and saying, "We can fix that right now," the door you are looking at is the only one you can see. And the consent form you signed 2 hours ago made sure of that. There is one more door in this hallway, and it has been locked since 2008, not by a surgeon, by a committee. In 2008, the Society of Thoracic Surgeons finished building something that should have changed cardiac care for every person over 65 in this country. It was a risk calculator, a formula. You put in a patient's age, their kidney function, their lung capacity, whether they have diabetes, whether they have had a stroke, and a dozen other variables. And it gives you a number, a percentage, the specific statistical likelihood that this patient will die within 30 days of this specific surgery, not a guess. Not a range printed in a textbook from 1997, a number built from data on hundreds of thousands of actual surgeries, updated every year. That calculator has been available to every cardiac surgeon in America for nearly 2 decades. It takes less than 3 minutes to fill in, and the number it produces is the single most important piece of information a patient over 65 could receive before signing a consent form. Most patients never see it, not because it is hidden, not because surgeons refuse to share it, But because the consent process was never redesigned to include it, the form still says, risks include death. It does not say, your risk of death from this procedure, based on your age and health, is 8.4%. It does not say, the national average for this surgery in your age group is 4.2%, and this hospital's rate is 6.1%. It does not say anything that would help a 76-year-old woman in a gown make an actual decision. Here is where you might expect me to say something about surgeons being greedy or careless. I am not going to say that, because the surgeon who recommended Walter's bypass in Loop 1 was not a bad doctor. The cardiologist in Houston who placed those stents was not a con artist. They were doing exactly what they were trained to do. They were trained to identify a problem and fix it. They were trained in a residency program that measured success by surgical volume and complication rates, not by whether the patient's grandchildren noticed something different about his eyes 6 weeks later. They were trained in a system that asks, can we operate, long before it asks, should we operate on this person? The failure is not the surgeon. The failure is the system that graduated the surgeon without teaching them how to sit across from a 73-year-old and say, in plain language, here is your number, here is what it means, and here's what happens if we do nothing. That conversation takes 11 minutes. A study at the University of Wisconsin measured it. 11 minutes to walk a patient through their specific risk, the alternatives, the best case, the worst case, and what doing nothing actually looks like for their condition. 11 minutes. The average pre-surgical consent conversation for a patient over 65 lasts less than 4 minutes. And in one study, surgeons discuss the patient's own role in the decision only 15% of the time. Let me say that differently. In 85 out of 100 consent conversations, no one asked the patient what mattered most to them. This is where the third door was locked, not by a person, by a design. The consent form was designed in a legal department, not a geriatric care office. It was built to document that risks were disclosed, not to help a human being weigh those risks against what Tuesday morning looks like at home. The STS calculator sits in the surgeon's computer. The consent form sits on the patient's lap. And between those two objects is a gap that 11 minutes could close, but 4 minutes never will. The procedure that sits in the middle of this gap is open surgical valve replacement. For decades, if you had a failing aortic valve, the fix was open heart surgery. Saw through the breastbone, stop the heart, replace the valve, wire the chest back together. 8 to 12 weeks of recovery if everything goes right. For a 55-year-old, the math works. For a 78-year-old with diabetes and moderate kidney disease, the math changes in ways the consent form does not reflect. The STS calculator knows the difference. The consent form does not. And for over a decade, a less invasive option has existed. I'm going to show you what that looks like in the next 10 minutes. But I need you to remember something first. Your surgeon is not your enemy. Your surgeon is a person who was handed a scalpel and a training manual and told that using the scalpel is how you save lives. The manual was not wrong. It was incomplete. And the clipboard you signed before the surgery was not designed to complete it. Doreen was 73, retired dental hygienist from Richmond, Virginia, the kind of woman who kept silk flowers on the kitchen table even in winter because she said a table without flowers was a table nobody wanted to sit at. She had a cat named Bishop and a daughter named Lena, who called every Sunday at exactly 4 p.m., rain or shine, even when Doreen told her she was fine and did not need checking on. Doreen's aortic valve had been narrowing for 4 years. Her cardiologist had been watching it on echocardiograms twice a year, noting the gradient, tracking the numbers. For 3 of those years, it was manageable, mild to moderate, no symptoms worth reporting. In October, something shifted. She could not walk from the kitchen to the mailbox without stopping. The 60 feet of sidewalk that used to take her 30 seconds now took 2 minutes and a hand on the porch railing. She told Lena it was the weather. It was not the weather. The cardiologist referred her to a cardiac surgeon. The surgeon looked at her scans, looked at her age, looked at her chart, and recommended open aortic valve replacement, the same procedure I described a few minutes ago. Saw through the breastbone, stop the heart, recover for 2 to 3 months. He said she was a candidate. He said the valve was not going to get better on its own. Both of those statements were true. What happened next is the part that matters. Lena did not sleep that night. She sat at her own kitchen table in her apartment and searched the internet for 4 hours. Most of what she found was written for doctors, not daughters. But somewhere around midnight, she found 3 letters that changed everything. TAVR, transcatheter aortic valve replacement. In plain English, a new valve delivered through a catheter threaded up from the leg. No open chest, no heart-lung machine, no saw through the breastbone. The procedure takes about an hour. Some patients go home the next day. TAVR has been FDA approved for over a decade. For patients over 70 with severe aortic stenosis, multiple clinical trials have shown outcomes that are comparable to open surgery. In some higher risk groups, the outcomes are better. Less time under anesthesia, less blood loss, less time in the hospital, less post-operative delirium, less of the thing that took Walter's words away. Lena called her mother's cardiologist the next morning and asked one question. Is my mother a candidate for TAVR? There was a pause on the line, not a long one, but Lena noticed it. The answer was yes, Doreen was a candidate. The cardiologist referred her to a different center that had a structural heart team offering TAVR. The procedure was done on a Tuesday. Doreen was home by Thursday afternoon. The following Wednesday, Lena called at 4 p.m. Doreen did not answer. Lena called twice more. No answer. She was about to get in the car when Doreen called back. She had been in the kitchen, making lemon pound cake. First time she had stood for an hour at the counter in 5 months. She did not hear the phone over the mixer. Doreen's follow-up was 3 weeks later. The cardiologist looked at her numbers and said something Doreen repeated to Lena that night. He said, "I did not expect it to look this good." He was not confused. He was genuinely surprised. The valve was functioning better than the surgical models predicted. Doreen's heart was doing the rest. Here is what I want you to hear. TAVR was not experimental. It was not new. It was not unproven. It was an established, FDA-approved, guideline-supported alternative that Doreen was never offered in her first consultation. Not because her surgeon was hiding it, because her surgeon was a cardiac surgeon. He does open heart surgery. That is his door, and he opened the one he knew. Lena found the other door because she stayed up until midnight and searched for it. A 73-year-old woman almost had her chest sawed open because her daughter happened to be the kind of person who could not sleep. That should not be how this works. The consent form Doreen never signed for the open surgery had every risk listed. What it did not list was TAVR. There is no box on a consent form that says alternative procedures available. There is no line that says a less invasive option exists for your condition. The form only describes the door you are about to walk through. It does not describe the doors you are walking past. You have been sitting with me for almost 50 minutes now. You know Walter's name. You know what happened in Houston. You know what the STS calculator is, and that it lives in your surgeon's computer and not on your consent form. You know Doreen's name and the sound of a mixer that saved her from an open chest. I need to tell you something about yourself. You are not the same person who started this video. Something has shifted in the way you see a clipboard. Something has shifted in the way you hear the word recommended. 48 minutes ago, your surgeon recommends this procedure meant the conversation was over. Now it means the conversation is starting. That is not a small change. That is the biggest change. Because the next time you sit in that room, or the next time you sit next to your mother or your husband in that room, and someone hands over a consent form with a pen, you are going to do something that 85 out of 100 patients in that chair do not do. You are going to ask 3 questions. The first question is, what is my STS score, or my specific calculated risk for this procedure? That question will tell you whether you are a 2% risk or a 14% risk. Those are 2 different decisions. The consent form treats them as the same decision. They are not. The second question is, what is the less invasive alternative, and am I a candidate for it? That question opens the other doors. It does not mean the alternative is always better. Sometimes the open surgery is the right call, but you deserve to know it is not the only call. And if your surgeon cannot answer that question, you deserve a second opinion from someone who can. The third question is 5 words. What if we do nothing? That question is the one most surgeons do not hear from patients over 65, because the culture of medicine, the training, the institutional design, all of it points in one direction. Do something. Act. Intervene. Fix. And for a 42-year-old with decades ahead of them, that instinct is almost always right. But for a 76-year-old whose definition of a good outcome is baking a cake on Wednesday, doing nothing might mean living the same way you are living now for 3 more years instead of spending 6 weeks unable to walk to the mailbox. That is a real option. It has data behind it. And it is almost never presented as an equal choice. You are the person who asks now. Not because you are angry at your doctor, not because you distrust the system, because you understand something that most people in that chair do not understand. The consent form was written by lawyers, the recommendation was shaped by training, and the only person in that room whose job it is to protect your Tuesday mornings is you. There is a moment that is going to come. Maybe next month, maybe next year. Someone you love is going to call you and say, "The doctor wants to do surgery." And you're going to ask them 3 questions they were not expecting. And when they do not have the answers, you are going to tell them, "That is okay. That is the point. Those answers exist. They just have to ask for them. That is who you are now, the one who notices, the one who asks." The 5 heart procedures you just heard are not the end of the list. They are the beginning. Because the same pattern, a surgery recommended without the full conversation, exists across every surgical specialty that touches patients over 65. Here are 10 more procedures where the wrong combination of age, frailty, or existing conditions turns a routine recommendation into something far more dangerous than the consent form suggests. Each one comes with the question you should ask before signing. Spinal fusion for chronic back pain if you have osteoporosis or diabetes. The complication rate doubles compared to a simpler decompression surgery. In one study, the rate of complex spinal fusions in Medicare patients increased 15-fold in 5 years, driven largely by device company marketing. Ask, would decompression alone give me the same pain relief? Knee replacement if you have uncontrolled heart disease. Post-operative cardiac events and blood clots spike in patients over 65. Pulmonary complications are twice as likely in this age group. Ask, has my cardiac risk been cleared, and what is my specific complication percentage? Bariatric surgery, if you are over 65. Adverse event rates exceed 20%. Mortality reaches 3.2%. The benefits in weight loss are significantly less than in younger patients. Ask, what is the expected benefit for someone my age compared to the risk? Carotid endarterectomy, the procedure that scrapes plaque from the neck arteries if you are asymptomatic. This procedure is listed by JAMA Surgery as uniquely high risk for patients over 65. For patients with no symptoms, the stroke risk from the surgery itself may be comparable to the stroke risk it is trying to prevent. Ask, am I symptomatic, and what does medical management look like for my case? Emergency open colectomy, removal of part of the colon if you are frail. In emergency settings, the death rate for frail patients over 65 is 11.5%. For severely frail patients, it is 25.8%. Many of these emergencies happen because elective surgery was delayed too long. Ask, can this be done electively now before it becomes an emergency? Open gallbladder removal if you are on blood thinners or have liver disease. This procedure is classified high risk in national surgical quality data for seniors. The laparoscopic version is safer, but not always offered when the situation feels urgent. Ask, is laparoscopic surgery an option for me? Whipple procedure, the complex pancreatic surgery, if you are over 75 with multiple conditions. One of the highest mortality operations performed on elderly patients. Even in high-volume centers, outcomes for older adults are significantly worse. Ask, what does my life look like with and without this surgery at my age? Radical prostatectomy, full removal of the prostate if you are over 70 with slow-growing cancer. For low-grade prostate cancer, active surveillance produces similar long-term outcomes without the surgical risks of incontinence and impotence. Ask, what is my Gleason score, and is active surveillance an option? Hip replacement if you have dementia or cognitive decline. Postoperative delirium and permanent cognitive worsening are dramatically higher in patients with existing cognitive impairment. The surgery may fix the hip and break the mind. Ask, what is my baseline cognitive status, and what is the delirium risk for someone like me? Hernia repair under general anesthesia if you have a heart arrhythmia. General anesthesia triggers cardiac stress that can cause events in patients with irregular heartbeats. A local anesthesia option often exists and is not always offered. Ask, can this be done under local anesthesia instead? 10 procedures, 10 conditions, 10 questions. None of them are on the consent form. You are probably wondering whether your current surgeon is someone you should stay with. That depends on one thing. Ask them your STS score or your specific calculated risk. If they give you the number and explain it in plain English, stay. If they wave the question away, get a second opinion. A good surgeon welcomes the question. Someone is going to ask whether this means all surgery is bad for people over 65. It does not. Surgery saves lives every day in this age group. The point is not to avoid surgery. The point is to make sure the conversation before the surgery matches the seriousness of the surgery itself. 4 minutes is not enough. 11 minutes is. You might be thinking that your doctor already explained everything. Maybe they did. But here is a way to check. Can you, right now, state the specific percentage risk of your procedure for someone your age with your conditions? Can you name one alternative that was discussed? If you cannot answer both, the conversation was incomplete. That is not an accusation. It is a fact you can fix by asking. Someone will wonder whether asking these questions will offend their surgeon. I have never met a competent surgeon who was offended by a patient who wanted to understand their own risk. I have met surgeons who were surprised. Surprise is fine. The 3 questions are not a confrontation. They are a conversation. The best surgeons I have observed prefer patients who ask over patients who just sign. Here is what the last 40 minutes actually showed you. You came here to learn about 5 heart surgeries. You did learn about them. But the pattern underneath those 5 procedures is not about the heart. It is about a gap. A space between what the system knows about you and what the system tells you before it operates on you. That gap exists in every surgical specialty. It exists in orthopedics, where a spinal fusion is recommended before decompression is offered. It exists in urology, where a prostate is removed before active surveillance is explained. It exists in general surgery, where a hernia is repaired under general anesthesia before anyone checks the heart rhythm that makes general anesthesia dangerous. The gap is always the same shape. A calculator or a data set or a clinical trial exists that could make the conversation better. A consent form exists that was never updated to include it, and a patient sits between those 2 things, holding a pen, not knowing what they do not know. You are no longer that patient, not because you memorized 5 procedures or 10 questions, because you learned to see the gap. And once you see it everywhere. In every waiting room, on every clipboard, in every 11-minute conversation that got compressed to 4. The system will catch up eventually. It always does. But you do not have time to wait for the system. Your next appointment is already scheduled. It is quiet now. The kind of quiet that comes after you learn something you cannot unlearn. Somewhere in a hospital right now, someone your age is sitting in a gown that does not close in the back. They are holding a clipboard, 6 pages, 2 signatures, a pen they did not bring, and no one has told them their number. You cannot reach that person, but you can reach the person at your kitchen table next Sunday. The one who mentions that their doctor said something about surgery. You can sit across from them, the way I have been sitting across from you, and say 3 sentences. Ask for your number. Ask about the other doors. Ask what happens if you wait. The next time someone hands you a clipboard, you will read it differently, and that is enough. If this reached you, save it. Send it to one person who needs to hear it before their next appointment. That is the only thing I will ask of you.